What's up, John? How you doing? Got them Shanks in the house, all right.
Hi.
Let's see, we got Dr. Lynn, where's he? Oh, hey, Bridget, are you on?
I'm here.
One thing I was gonna suggest, Bridget, I don't know if you can remove the Teams start thing. When I initially clicked in, it was like taking me over to Teams. I don't know how we do that.
Oh, can you hear me?
Yeah,
Okay. I think it's just because I used the same um, appointment. I tried to update everything that said Zoom, or I'm sorry, that said Teams to Zoom.
okay. Maybe that's a me problem.
Yeah, when I clicked into it, I didn't. I was looking for a join the Teams meeting and did not see one, and only option was to join Zoom.
Oh, okay. Maybe, I don't know what. All right. Okay.
So
Well,
yeah,
hey, all right, Dr. Lynn, you made it. Thanks for joining us.
Good to see everyone. Thanks for inviting me.
Yeah, we're excited about this. We will give it a few minutes. Yeah, usually we let people kind of get out of their morning clinics and things like that. So we usually start around 12:05, or was that 10:05 your time? Okay,
Yes. Yeah, totally understand. No problem.
get a few minutes here. So Dr. Lynn it seems like I was kind of interested looking at your CV that, so you guys kind of have a combined division of some sort, it seems like, with kind of multi-specialty primary care, or is that?
Yeah, we don't have a Department of Family Medicine or a Department of General Internal Medicine at Stanford. We have a mega division that is family medicine, general internal medicine, geriatrics, and palliative care.
Boy, that is a big division. Okay,
It's huge. It's bigger than most departments at Stanford. But for historical and political reasons, we are technically a division within the Department of Medicine.
okay. Oh, that's really cool.
I
So
think
yeah, your audience today here at the University of Canada, so we have family medicine, Department of Family Medicine, we have the and then general internal medicine as well. So you will kind of speak, and then we have some folks from our community department as well, and some of our community sections. So we kind of bring together, although we're all different departments officially for our primary care grand rounds, we kind of bring everybody together for that. And so you'll have that kind of full audience for us. So we're excited.
I
Sorry,
love
Dan,
that.
didn't mean to interrupt you there.
I was just saying I like Stanford's approach to primary care, bringing everyone together and forming a massive primary care team.
Thank you.
All right, guys, let's see how we're doing here. Starting to get a quorum developed, I think. Give it one more minute and then we'll kick it off. John's put together some good cases for us to frame our discussion, but as always, we want this to be interactive, and we love it when the audience brings more questions than we do. So, but John and I have questions to fill the void if we need to, but please put them in the chat. Raise your hand, however you want to do it, and we'll try to get your questions answered with Dr. Lynn. All right, let's go ahead and get started. It's 12:05. So welcome, everybody. Thank you for joining today. So this is going to be a little bit of a different talk today than some of our standard primary care grand rounds. So we're going to talk about AI, particularly in primary care. And I just learned this morning that there is a difference between AI and machine learning. And so there's some of us who are on the very basic end of understanding of this, and I think we have some who are much more expert, but we'll try to get everybody's questions answered. So we have an amazing expert with us today, Dr. Stephen Lin, coming from Stanford. He is a family medicine physician who is the chief of general primary care and also the head of technology innovation for the division of primary care population health at Stanford. He's done a lot of work in AI and machine learning, been very productive from a scholarly standpoint. So I kind of emailed that out this morning, but over 500 scholarly works, conference presentations. But a lot of his recent work is focused on artificial intelligence and machine learning. And so obviously couldn't have asked for a better expert to join us today. And so, Dr. Lin, we just appreciate your time and sharing your expertise with us.
Thank you for the invitation. Really excited about the conversation. And thank you, John, for making it easy for me by making it case-based and conversational. I so appreciate that, as opposed to, the standard lectures.
Right. Yeah. My job is to watch your lecture ahead of time and ask any questions based off of that if I find any, but it's like these are so engaging, so fun. This is one of the, it's one of the people that like Brandon calls me about whenever you agree to do it. And he's like, how did you get, Dr. Lin to do this? And I'm just like, he's just really nice. He's really nice over email. So, and he's passionate about it. So I just love it. So we are so fortunate to have you. So we're not going to show the PowerPoint slides just so that we can leave way for people who want to jump on and have their camera on to talk and to ask questions and just to keep it so that there's not one person being highlighted at any given point. And so the objectives that we're going to focus on is learn. I realize that I set an objective that's like a 4-hour lecture in and of itself, or like a college course. But let's learn a brief history of AI in medicine, how it's developed, kind of talk about the high points between like typical AI that we think of, machine learning, all the way down to generative AI. Discuss ways to improve efficiency in the clinic using AI. Discuss ways to improve clinical decision making using AI in clinic, and then focusing on technologies on the horizon as they relate to primary care. And so the case that because we're going to be looking at this in a case-based way, and the case will revolve around me when I started as a first-year attending and how AI could have helped me in that situation because it was a very stressful year. But let's start with the basics. So Dr. Lin, could you please just give us your elevator pitch about how AI has kind of transformed in internal medicine over the last several years?
Yeah, I'll try my best. It's been a rapid evolution of technology over the last few years, not just in the capabilities of the technology, but also the impact sort of culturally, societally. And I think what we've seen over the last really 5 years has been the deployment of very specific technologies that have been largely to now focused on administrative burden reduction, which I think is a really good thing when it comes to general internal medicine, family medicine, primary care. Administrative burden is one of the things that shackle us to the clinic and really drives burnout. And so one of the things that is probably the most widespread application of AI technology today is the ambient AI scribe. I like to think of it as more than just a scribe, because for most of the vendors out there, you're seeing them have additional functionality now for like the ability to pen orders based on the conversation that you're having with the patient. But for the large part, their core functionality is to listen in on the conversation and document your note for you. Structure it in a way that's more than just a transcript, but in a way that's a readable, usable progress note, and significantly reduce your time to write all of the notes at night, which I know many of us do during our pajama time, and is the second largest time suck in the EHR after chart review. That's the thing that I think most physicians think about when they hear AI, because that's the thing that they see most of. But there are other applications that are coming on that are particularly helpful for primary care. Chart review tools, for example, tools for in-basket management, the ability for large language models to draft replies to patient electronic portal messages that you can edit and then send back. The ability to automatically generate lab letters and radiology letters with language tailored to the patient reading level. and removing the medical jargon, translating into something that's accessible for the patient, so it saves your time reviewing and interpreting lab results and radiology for your patients. Prior authorizations, the automation of prior authorizations in some settings, and triaging. So the ability to provide some smart, intelligent medical advice for low risk use cases that can, in some cases, reduce the need for visits by up to 25%. Those are some of the areas in which we're seeing more traction within primary care. And I like these types of use cases because they really go to the heart of the clerical part of medicine that really burdens and reduces our joy of practice. And then I think what we're going to see over the next 5 years will be, I'll say, more advanced and perhaps higher risk use cases like clinical decision making, which we are already seeing some of, but maybe not as much in primary care as in other specialties.
John, you're on mute there.
Sorry, Zoom. Yeah, sorry. We're usually on Teams, and I swear I'm better at Teams. So we are so used to AI utility outside of medicine. I think the very much quicker in adoption in that realm, and I think it makes sense because it's a higher risk setting, asking clinical questions to something and having it give you an answer and having that have potential legal ramifications. So are there any other kind of situations in where AI is more difficult to adopt widespread, or any other reasons why widespread adoption in clinical medicine is much more difficult than, say, the general public and other domains?
Yeah, a lot of the technologies now, particularly generative AI with ChatGPT sort of really kicking this off into the public consciousness, is geared towards not us, but everybody. And for the most part, I would say the average consumer, the average person outside of the healthcare industry probably has more experience with AI than we do right now. Healthcare is just a more conservative and sort of safety conscious industry. And I think that's a good thing. I think that's a good thing in general, that we are intentional about our adoption of AI technologies. Because the truth is, a lot of these technologies are not evaluated in the same way, in the same rigor that we expect of pharmacotherapeutics or medical devices. There's not the same studies and level of evidence that's out there for even the types of AI technologies that have already been implemented. And so we need to be very, very cautious. More than 95% of healthcare AI models that are built, more than 95% are never put into production. And so they are made, they generate some headlines, they die in literature and never get implemented to the bedside. So it's only a fraction of those that sort of make it through. I think there's many reasons of that, but overall, I think it's a fairly good thing. And what we need to do better at as a workforce is to engage in the innovation process, so that we are, at the table, not on the table, and being able to guide some of these developers that they're well-intentioned but have no sort of understanding of the challenges that we face in real clinical care, in order to make sure that those products work for us and work for our patients. So we are slow. We are slow in adoption, and I think that's okay. In many ways, the implementation science of AI really needs to catch up to the basics and data science side of AI in order for us to be able to trust our technology and to widespread implement some of these newer applications.
Yeah.
I'm going to send this video out to the entire group because it's a really nice video. And you gave a talk a couple of months ago with another group, but basically you walk through a patient in the primary care setting, like Juan, and you talked about kind of all the different ways that you utilize AI to help you in not only being efficient, but giving the patient really nice, like an after visit summary of what happened and all these things. So Dr. Alhi has a really nice question, and where he just asks, can you just essentially walk us through that patient? Like walk through how you use AI from start to finish, chart review to note closure.
Yeah, happy to. And that case that you mentioned, Juan, it's based on a real patient of mine. I changed the names and tweaked a little, but the applications of the technology in that particular case is all stuff that we've been able to test and then integrate into our standard primary care practice at Stanford. And so the case, for those of you who haven't been able to see this, is a diabetic patient who I haven't seen in about 3 years, who was recently in the hospital for a new diagnosis of congestive heart failure and is following up post-hospitalization to see me in 3 years. And so the first challenge that I mentioned in this case is the fact that we carry large panels. Our patients have many different types of journeys and happening with specialty in the hospital, in the community. And when they come to our office, we need to know what's been happening to them since the last time we saw them. And chart review is the #1 time suck in terms of how much time primary care doctors are spending in the EHR. It exceeds even the documentation burden, which is what most people think about. But chart review really is very time consuming, and I would argue clinically significantly more important than the clinical documentation piece. So that's the first sort of barrier that we face in clinic. And there are tools now that can help us with chart review, gathering the rich unstructured text that lives within our notes, pairing it with the structured data elements like labs and radiology to form nice summaries of the patient. I would liken it to sort of the sign out that you get from a intelligent, well-organized, and succinct resident, for example. And so we have tools now that are able to deliver those summaries. And I was able to get one of these AI summaries from our tool. And I learned very quickly that I'm about to see a patient that I haven't seen in 3 years. Their A1C is 9.0. They were just in the hospital for a new diagnosis of congestive heart failure. And these were the things on the discharge summary that I needed to pay attention to. And that was really, really helpful for me in order to know all of that before I stepped into the room. And then I stepped into the room. I saw the patient. Patient was clinically stable. And I did sort of all the tasks. I made sure that they had all their medications. But the inpatient team didn't really address the A1C of 9. They stabilized the heart failure, didn't address A1C of 9. So the second thing was, what is the best medication for this particular patient, given their conditions, based on the most up-to-date evidence and clinical guidelines? And so that's the second part that I mentioned in the video, which is it is impossible for a human being, as smart as you are, as smart as all of us are, to keep up with the rapid advancement in medical literature. There's some crazy statistic like medical knowledge now doubles every 3 to 4 months or something like that. And guidelines change all the time. And so AI, here's where AI can provide you with the most up-to-date recommendation that's tailored specifically for the patient. And so our clinical decision support tool here was able to identify that the patient was diabetic, that the patient has heart failure, and that what was missing in the patient's guideline-directed medical therapy regimen was an SGLT2 inhibitor. And so it was able to say, I should prescribe one. And so that allowed me to prescribe dapagliflozin for this patient and explain why. And then I prescribed that medication. We talk about his congestive heart failure. He has tons of questions. He doesn't know what he should be eating now. He doesn't know why. And none of that was, discussed, of course, during his hospitalization. And my 15 minutes are up with him. Right? So what do? So the next problem that I highlighted was the inability for us in modern day practice to give tailored, personalized patient education that is directly applicable for the individual in front of us. And so AI has the ability now to take all of the information and generate personalized after discharge, after visit summaries and patient instructions that are language concordant, reading level adjusted, specifically tailored to the patient. And in studies that we've done at Stanford, significantly better than the ones that we generate right now by hand. And so my AI was able to generate that. It produced a heart failure action plan. It produced a culturally sensitive diet plan for this particular patient at the reading level that they needed. So he goes home and finally understands a lot better, what he should be doing for his congestive heart failure. And I see, 20 patients like that. And at the end of the day, I have 50 notes that I need to write. What do I do? Well, thankfully, all of this was done with an ambient AI scribe in the background. And so all my notes were done by the time I finished seeing the last patient. I review the notes, of course, and sign off on them. It takes me a couple of minutes rather than a couple of hours. I'm able to go home and spend some time with my daughter and not use my pajama time on documentation. So that's like one example of a couple of different use cases. I could go on, but I don't want to talk for continuously for too much longer. But obviously, you can think about, that's one sort of face-to-face visit. There's a whole bunch of other applications that occur during the interstitial space between visits that we can talk about with in-basket management, patient portal messages, prior authorizations. All of those now have AI use cases and companies that produce solutions for those things as well. So along the entire patient journey and the physician journey, there are many, many AI use cases that are quite interesting for primary care.
So, Dr. Lin, this is fascinating. And I just, are you kind of talking like these are the possibilities, or are these things that at Stanford you all are
Today.
employing? And then I guess, are they mostly third-party kind of vendor things coming in, like the ambient scribe, or are these embedded within, I assume you guys are on Epic too, or something, that's our EMR here. Are these tools embedded within the EMR system already or something?
Yeah, great question. So everything I described in that video exists today. We're using them today. It's not aspirational. We're doing it today. There are tools that we use that are third-party vendors that are integrated into Epic. For example, the ambient AI scribe solution that we use at Stanford is the DAX Copilot Microsoft Nuance product. There are others that you may be using, that others are using, that are integrated with Epic or Cerner. There are those that are out of the box Epic tools that are available. For example, the chart summarization tool, there's an out of the box version right now that institutions can turn on for Epic if they wanted to do that. And then there are those that are homegrown. And so we have a homegrown system called Chat EHR, where we're able to use natural language queries into the EHR and be able to get really nice, rich summaries from the EHR through the unstructured data elements that it would take forever for us to do that kind of review or to put together prior authorization letters. And so it's all three. And I think the challenge that many institutions face today is, what do we do? Do we partner? Do we build? Do we buy? Do we co-develop? There's no right answer. I think the most important thing is to have some sort of governance model at each institution that can help you make those types of decisions with clinical input from clinicians.
And then I have just this might be a little off topic, but just from advocating for some of those changes within an institution, are there kind of, returns, so to speak, that you're seeing that you can kind of highlight to the administration around patient outcomes or cost or anything like that that can help justify the expense of some of these new tools?
Yeah, the defining the ROI is challenging for a lot of these tools because there's not a lot of evidence out there, and then depend on who you talk to, ROI is different for everybody. I would say the most widely developed tool right now, most widely disseminated tool right now is the Ambient AI Scribe. There's tons of evidence on that. We know it saves time. We know it reduces burnout. We also know that patients they like it. They like it, and they often say that their physicians are spending more time with them face to face. They feel deeper connection. They feel like they understand their care plans better. And so, all in all, the results for that is pretty good. So, from an ROI standpoint, you can use the time savings. You can use the patient experience as ROIs. The cost needs to be balanced as well. Some of these tools are costlier than others. Some institutions have sort of institutional licenses per provider licenses. Other contracts are billed like per note, and so those will be of varying cost structures. The difficulty with scribes, just to be very, very transparent, is if you say that this saves you time, will then the hospital and the health system force you to see an extra patient or two extra patients or something like that? That's something at Stanford we pushed back very, very, very hard on. And we have not asked our clinicians to see more patients. We kind of see this as getting them right-sizing the level of support that they need for the care, the level and intensity of care that we deliver today. And they are able to do more during that visit because of the clinical documentation support. And we say that actually helps with downstream unnecessary utilization, quality, unnecessary ER visits, things like that. And at least right now, our system leaders see that as the return on investment and are not forcing them to see additional patients, which I would highly suggest to all institutions. But for some of these other use cases, it's a little bit harder to determine the ROI. In-basket management is another one that I think is at the top of a lot of folks' GER list. These thousands of portal messages that come in. The ability for large language models now to take the patient's message, contextualize it with the EHR data, and then draft really quite good, nuanced responses that the physicians can edit and then send back is really, really powerful. And obviously, sort of the reduction in cognitive load and burnout is a good ROI. Patient satisfaction is a good ROI there. Unnecessary utilization may be another ROI, particularly if your institution has a large accountable care lens or specific accountable care or risk-bearing populations that they need to care for. So I would say oftentimes the ROI is multifaceted, and it's best to sort of approach it that way rather than just sort of a dollar-to-dollar comparison, because that's really tough.
Very helpful. Very helpful. All right, John, should we go to the chat? We got a couple of good questions in the chat.
Yeah. Dr. Stand, I was wondering, just going back to the case, when you're talking about the AVS material, is that something that you, and Andrew, I'm sorry if I'm misinterpreting your question, but I think it's saying basically, did you come up with the plan and the after visit summary yourself? Is this the discussion between you and the patient, and then the AI just put it into an AVS for you? Or did you go out and you say what you wanted the system to generate for you, and then it did it, and then you went back in the room?
More the latter. And so I confess I am not a nutritionist. I like many of us in allopathic training, we don't get a lot of like nutrition education. This particular patient of mine is of Hispanic origin. I don't quite understand what is culturally sensitive sort of heart failure meal for them. And so that's an area of knowledge I just don't have. But in this case, I was able to ask the AI, hey, here's some information about my patient. My goal is for you to produce a culturally sensitive diet plan that adheres to, American Heart Association heart failure guidelines for a healthy diet. Please produce that in Spanish at a 8th grade reading level. And that's what the AI produces.
It's really helpful. Dr. Shanks, do you want to just ask your question? Dr. Shanks is like our Dr. Lin, and so this is like the meeting of the minds right now.
Yeah, I actually reached out to Dr. Lin just a couple weeks ago, and I'm trying to work with Tyler to schedule some time for us to meet. But yeah, happy to be here and happy to chat. And I mean, lots of questions, lots of things to talk about. But one, you started to talk a little bit about governance and everything. So I was just curious how your governance structure was for AI, your leadership structure for AI, and some of that may be in your very large department of primary care, and some of it may also be more health system wide or health system and academic, and expanding the whole spectrum. So
I'm happy to and I'm happy to connect also separately for more detail. But the basic structure is, and I'm not exactly sure the structure at University of Kansas, but it may be similar. Stanford School of Medicine is one entity, and all of the physicians are employed under the school. We have Stanford Healthcare, and that's the health system, and our extended care teams are employed under that latter. The basic governance structure is that there's a data science team that's on the school side, a technology and digital solutions team, TDS, that's on the health system side. And the structure that's set up is that there's an overall committee, overall AI committee formed up of leaders on both the school side and the health system side that coordinates the activities for these two major groups. And they work together to do intake and implementation. Intake can come from many different sources. Sometimes they're identified by clinician leaders who are saying that there's a need for some technology solution. They might even have been approached by industry, or maybe it's a homegrown sort of research project that happens within their department. Anyways, they sort of pitch it to the committee, and the committee has a standard framework for evaluating the use case itself, which includes a cost effectiveness evaluation, as well as a ethical evaluation. And then they basically make a recommendation to the executive committee for whether or not this would be something that Stanford wants to adopt and deploy. And then that committee is in charge of deciding what to do. Sometimes the intake comes from Epic. So Epic has its own roadmap of different types of AI solutions. They just had a conference recently where they laid out their roadmap for the next couple of years for what they want to do. And part of that committee's job is also to figure out which of these are we interested in looking at evaluating. And then for my team, we have a applied AI research team that I founded about 7-8 years ago. That is sort of our primary care representation for all of this governance. And we work very, very closely with our AI governance to test these solutions. So a lot of the times we will be the first ones to pilot it. So it's really nice that I have both a sort of an AI implementation research role, as well as an operational hat as the chief of primary care. And so I can sort of make that happen. Oftentimes we'll raise our hands and we'll be the guinea pigs, we'll be the pilot testers at these clinics. And we do rapid cycle evaluations, and we produce scholarship on it. And that scholarship helps with the academic side of things on the school side, but it also helps the health system then make decisions on whether or not they want to proceed, or do they want to sunset that technology after the pilot. So that's kind of the basic structure that we set up. One thing I'll say is that I have found a implementation science team within primary care to be very, very, very helpful. We don't have many of those at Stanford. Actually, we're the only ones, and we happen to be in primary care, which is doubly helpful for us because it means that we get access to the technologies first, and we get to provide input on that. And so you may have within KU many groups that are doing AI related work. I suspect that many of them are fairly upstream in development work, basic science, data science stuff. And one thing that I highly recommend whenever I talk to folks is to develop a separate arm that is really focused on the implementation side of things that are staffed mostly by clinicians, improvement specialists, and folks who really understand how things look on the ground, because you need those folks to work with the data scientists to make sure that the tools are actually implemented well.
Thank you.
John, you're on mute again.
Muted again. I found it that time. I didn't even need you to tell me. So we're about to jump into the case. I do want to ask one thing because I'm just afraid that I'll forget, and I don't think it's labeled any other place. Is that what are the guardrails that medical AI clinical decision-making tools operate within? So like when we're asking a question of, brand name open evidence, or if, UpToDate has, their AI generative tool now, do they operate only within New England Journal of Medicine, or do they take things from outside? Because like the fear from a lot of people with quick adoption is that it's going to start hallucinating and telling us things that are not necessarily true or clinically relevant. So like, how do we abate our fears with that?
Yeah. So all large language models have the ability to hallucinate. That's really important for folks to know. It's just the way that the AI is made, and we won't use time here to talk about technically why that's the case, or how generative AI is built in general, but any large language model can hallucinate. So if any large language model tries to advertise itself as like they never hallucinate, I would question that seriously. But what you can do to make things a little bit safer is to figure out, is to define where they're drawing their sources from. So if you're using like a commercially available Claude, Gemini, ChatGPT, just know that they're drawing their sources from everywhere, the entirety of the internet. And that's where you're going to probably get answers if you're looking for clinical evidence-based answers, for example, that you're going to have to vet very, very, very carefully. We have situations where folks have used commercially available large language models for research and to do literature reviews, or to answer a patient case. And the large language model is so good at hallucinating that it not only makes up citations, but it makes up the DOI PMID numbers for those citations to trick you into thinking that it's a real citation, because they know that if you see a DOI number, you're more likely to think that it's a real citation. Like, it's really, really good, right? Large language models are basically just, people-pleasing next word generators. And so they will generate stuff to please you. So that's really, really important. Stuff like open evidence and other more custom GPTs. Like if you go to the GPT store, there'll be custom GPTs that are like specifically tailored for research. For example, like Scholar GPT, or Gemini has sort of like a deep research mode. Those are trained slightly differently, and those do limit their sources if you want them to specific trustworthy sites and sources. And I would recommend those in general, but you still can't just take everything that they give you at face value. I would still recommend checking everything very, very carefully, especially if you're using it for clinical decision making.
Okay, let's jump in. So 20 minutes left. Perfect timing to get into the bulk of the cases. So this, like I said, this focused on me when I started, just as kind of a point, because I couldn't think of a clever name. So Dr. Logan is just starting out in clinic as a first-year attending. He finds himself running behind in clinic frequently as he tries to keep up with his clinical workload, but notices that writing the notes, putting in orders, keeping up with his in-basket is overwhelming. He hasn't yet developed a system to seeing his patients or writing his notes, and he's wondering if there's ways to be more efficient in clinic. I think we've talked about this quite a bit already. I think, maybe only 10% or, 20% of our actual faculty has been practicing 10 years or less. And so I'm really curious how people who've been practicing a little bit longer, who may have a structure already identified, how AI fits into their workflow. If there's my workflow is fine, I don't need any help. Like, where would your argument be that no, these are the places that I can help you?
Yeah, I don't think that there's a one size fits all approach. For example, I'll say as much as I am a proponent and I really think a lot about this stuff and I do research and stuff, I don't actually use an AI scribe. But that's because I have developed a very efficient documentation process, and that is not a place where I need help. But I do need help with my in-basket. And so I'm happy to use the in-basket tools that we have, the draft replies, the lab and radiology explainers. I use those for sure. I definitely use them for prior authorizations because I don't like doing them. So I don't think that there's a one size fits all approach. Folks will adopt tools where they see benefit and need help, and not everybody needs help with documentation. I'll say that. We don't we offer these tools to our primary care doctors, but we don't force them to do it. I would say we've been doing it for a couple of years now, and I would say probably about 2/3 of our providers are regularly using an AI scribe, and the rest is just they're fine. They're fine doing what they do, and they write good notes, and they always go home with all of their charts closed, so they don't really need it.
That must be nice. That sounds
Yeah.
like a fantasy world.
John, can I jump in with the
Yeah,
perspective,
please.
kind of going back a little bit of how you all are using it at Stanford? Are you using AI at all or machine learning, any of that stuff for kind of predictive analytics, and particularly, one thing we've had a lot of conversations around here about, we're pretty good at identifying those 20% of our sickest patients, right? Where we really are trying to go to is how do we predict those patients who might be in that 20% next year or something like that. That's one example of how we've been discussing how to try to implement that. But are you guys doing anything like that in your population health management kind of hat and that sort of thing?
Yeah, so on the inpatient side, we've implemented system-wide a couple of predictive models. One is a mortality prediction model. So for all of our patients that are admitted to our inpatient services, there's a model that runs in the background that's homegrown, and it predicts their risk of dying in the next 30, 60, 90 days. And what we're using with the prediction is to make sure they all have advanced care plan discussions, and they all have advanced directives documented in the system. For those who don't, we have a workflow that basically triggers an automatic social work and palliative care consult to make sure that all of those patients that are in the top quartile of mortality risk will leave the hospital with a good serious illness and advanced care conversation before they leave the hospital. There's another one that is looking at predicting clinical deterioration. This one is an out-of-the-box model. It basically predicts for our floor patients the risk of RRT, ICU escalation, something bad happening essentially, and it updates basically every several hours, and we get a page if the model flags something. Usually it's like vital sign trending the wrong way, something on the labs that's a trend that somebody missed, something that's happening sort of short interval within the last 8 hours. We're able to detect that and hopefully prevent an escalation. And we've shown that in a study where we were able to prevent ICU escalations and codes with that tool. On the outpatient side, we're really looking at this, like what you were saying on the population level. We have a couple of accountable care programs, Medicare shared saving programs that we're a part of, and so we're learning how to do that better. So that's all about predicting ED visits, and particularly not just identifying folks who are at high risk, but then can we identify folks with rising risk? because, as all of us knows, there are hard rocks that are always going to be high risk. They're going to be high risk forever for the rest of their lives. There's not too much we can do about it. But it's those who are like not currently high risk who are going to be in the high risk category in the next 6 to 12 months that we need to find and intervene on. And so those patients, particularly around ambulatory care sensitive conditions, we have developed models where we can fairly accurately predict the risk of a unnecessary ED visit and then intervene. Usually that means getting them into care, but we've also built care gap closure identification tools where, for example, for the heart failure patient, they will be able to say, oh, you're not quite meeting GDMT, you're missing this drug or that drug, which many population dashboards that are sort of out of the box, like Epic, for example, Healthy Planet and others, they have more process metrics like your A1Cs and stuff like that. They don't go into that level of detail of, oh, you're missing a GDMT drug. So those have been helpful for us.
Yeah, can you just go a little bit, like just a slightly deeper on some of that? These ambulatory care sensitive conditions, you have some AI model working in the background. Like, who does that notify? Like, okay, we have a person that we think is rising risk, or the computer recognizes that. Does that go into some inbox or the primary care physician?
Yeah,
How
we've
does
experimented with a couple of workflows. I'll tell you what doesn't work. Sending it to the PCP doesn't work. What works better is sending it to a centralized pop health team with the care management sort of resources like RNs that are able to make phone calls and get those patients back into practice. And then we've been able to, in some cases, like for example, for diabetes, put in co-management protocols where the clinical pharmacists can directly reach out to at-risk diabetic patients and engage them in titration of their medications directly without necessarily having to see the MD, ordering labs and things like that. So I think the key here is like team-based workflows, not relying solely on the PCP, which is not going to work.
Yeah, and adds to the inbox management as we talked about earlier. Okay, we got a question in the chat around, there are a couple questions here. So around the environmental impact of these tools, is there a way to mitigate that? Any concerns there?
Oh, huge concerns. I'm so glad that this is something that folks are starting to care about, and I'm really proud that it's really the primary care community that's bringing it up. But there's an increasing recognition that the training of these tools, the maintenance of these tools is highly energy intensive. And we are at a point where I think we need to, going back to your ROI, your point about ROI, like should environmental impact be part of that equation as we're thinking about the risks and the benefits and the ROI. We are very early in this. We are doing a study right now where we're looking at we're trying to calculate the environmental impact of the actively deployed AI tools at Stanford. So mainly around the ambient scribes as well as the large language model draft replies to patient portal messages. We're trying to calculate what that means in terms of a carbon footprint every year. And then we're going to publish on that soon and then surface that to our leadership as to our governance committee as part of a ask for them to think, at least for awareness, like this is really helping us and we should be aware that this is the environmental impact. What can we do to offset some of that environmental impact? And my personal goal is that eventually, a few years from now, we'll get so good at calculating environmental impact that we can plug that in and bake that in to our formal intake decision-making process up front before we implement an AI tool. Like we have a sense that, okay, we do a cost-benefit analysis, we do an ethical analysis, but we also do an environmental impact analysis to make sure that it makes sense.
Dr. Yudlinsky also had a second part of the question where she basically says, is there a way to mitigate it? Like if we put up stricter guardrails, if we phrase our question so that it searches less things, does that use less? And like, you know, small differences, but on thousands and thousands of searches, maybe makes a difference.
Yeah. So the first thing I'll say there is that not every problem needs to be solved with AI. So I know that's the cool thing to think about right now, but I would say there's a cost with implementing AI. When we need to kind of ask ourselves, does this particular problem really benefit from an AI approach? If the answer is yes, we also have a decision. Do we need a generative AI approach, or can it just be a traditional AI approach? Because in general, generative AI approaches are going to be far more uh, costly in every sense of the word, including environmental. And so, a lot of clinical decision support tools, for example, is traditional AI. It's rules-based traditional AI. You don't get a whole lot more by incorporating generative AI to it, for example. And so what I say is, first, be really, really thoughtful about whether AI is even needed in the first place. And then, are there ways that we can use more environmentally conscious as well as less costly uses of AI if the incremental benefit of generative AI is not that much above traditional AI approaches, then we should just use traditional AI.
Yeah, okay. Couple good questions in the chat here we'll get to. I think this is going back to the pop health predictive analytics stuff. So what Epic tools are you all using to track and operationalize these workflows? I think it's the workflows that we were talking about with finding the rising risk and coming back to a team-based. Are there any specific Epic tools that you're all using?
Compass Rose as sort of our basic case management sort of workflow tool is probably the one we rely on most. Do you all use Compass Rose?
No, but we've been trying to get that for a while.
It's okay. Like a lot of things Epic builds, it's fine. I probably wouldn't have designed it that way, but from speaking to our care management teams, it works decently well with multidisciplinary, interdepartmental communications and care management and task tracking.
Okay, cool. And then a question here about how are you informing patients about the use of AI in their care?
Yeah, really, really great question. We inform all of them. There's a standard protocol where our medical assistants, upon rooming, for example, if the clinician is using a scribe, will let them know that, and the patients can opt out if they want to, and the clinicians will be informed that the patient is opting out. Very, very few patients opt out, but I think they do appreciate the consent. Because we know that in some of our clinics where that workflow wasn't implemented, there have been complaints and patients just being caught off guard that the provider is recording a conversation and they didn't know much about it. In our AI generated responses to the patient portal messages, there is an icon that shows up in the message in our response back if the draft was assisted by an AI. And so the patients will know, oh, the draft was initially created by AI, your doctor saw it, edited it, and then sent it to you. And so we try to be as transparent as we can. There are use cases that I think that's a lot harder. Like, for example, the population health use cases that we were just talking about, the risk prediction use cases we're talking about, that's a lot harder. Like, how do you can't easily consent the 100,000 patients that you're accountable for within sort of your population health framework. And so that's a little bit harder. We try to bake that into our general treatment consent authorized. So it's sort of like we're using your data to provide the best care for you as much as we can. A lot of that is baked into that sort of general treatment authorization consent process. But for everything that's new, that is obvious, like patients are seeing a technology being deployed in front of them, recordings being made, our policy has been to disclose and be transparent and give them an opportunity to opt out.
I'm just going to mention that in many ways is a state by state law. In Missouri and Kansas, we don't have to ask for consent to record. Our hospital policy is that if the patient would like to record, they need to ask for consent because that's more of a hospital policy, but the states say that they don't. And so in our health system, we worked it up the process, and there are lots of technologies that we use for patient care. And when you sign up to be a patient, you're opting into the variety of technologies that we use on a regular basis. I think it's perfectly fine to have your own saying to tell a patient that you're recording or something. However, you also don't want mentioning this technology that is absolutely widespread and everything now and validated by research to get in the way of actual clinical care. And so, but yeah, in general, at our health system, we don't have to ask for consent for that recording.
All right, we are nearing the end here. So, any other questions from the group? You know, I would consider this just a very fascinating topic, very fascinating primary care grounds, Dr. Lin. The engagement in the group was fantastic. We love that. We consider it a success if we've only gotten to one or two of our own questions. And so we appreciate everybody's engagement in this. Dr. Lin, boy, we're going to have you come back because we have a lot more questions for you. You're obviously, you know, out in front on these issues, and we just really appreciate you sharing an hour with us and you know, helping us kind of navigate this new world we're in. So we really appreciate it.
Well, thank you for inviting me. Thank you for making it fun and easy, and I'd be happy to come back.
All
Thank
right.
you.
Thank
Bye,
you,
everyone.
everybody. See you next time.
Bye, everyone. Take care.